teenagers. The American Academy of Pediatrics has declared the crisis a national emergency. We have two Duke pediatric psychiatrists with us this morning, plus a behavioral health analyst to discuss this growing problem and what parents and caregivers can do to help. With us this morning is Dr. Nathan Copeland. He's an assistant professor in the Duke Department of Psychiatry and Behavioral Sciences and an attending child and adolescent psychiatrist at the Duke Center for Autism and Brain Development. Also joining us is Professor Sharika Hill. She is an adjunct assistant professor in the Department of Psychiatry and Behavioral Sciences. Professor Hill is a clinical researcher who studies pediatric mental health and well-being. And also we have Dr. Gary Maslow. Pulling up my notes here, sorry about that. Dr. Maslow is an associate professor in the Duke Department of Psychiatry and Behavioral Sciences and co-director of the Division of Child and Family Mental Health and Community Psychiatry. Good morning to all of you. Dr. Copeland, we'll start with you. Can you describe the current situation and give us some sense of how much it's become worse over time?
Sure, absolutely. Well, thank you for that question. I'll spend a few minutes kind of laying this out and setting the stage. The first place I actually want to start is pre-pandemic, 2019. So before the pandemic in 2019, suicide was the second leading cause of death among children and adolescents. Among the 10 to 24 age group, suicide accounted for nearly 25% of all death among kids. And among those individuals 15 to 24, suicide accounted for more death than the next 7 medical causes combined. In 2019, what we had been seeing was a rate increase for the previous almost 2 decades. In 2019, suicide, more kids killed themselves in 2019 than at any point in American history. But the trends that we were seeing were uneven, right? There were certain groups that were being harmed more by suicide. There were certain groups that we were seeing the rate increase faster than others. And that was, in particular in America, that was Black youth, where we were seeing things like systemic racism and how it was impacting Black youth. We were seeing that rate increase faster for Black youth than any other demographic, to the point that the Congressional Black Caucus wrote a white paper on this topic, bringing together experts to the field to discuss suicide in this population. And in talking about suicide, you know, there are probably a lot of things that make suicide so common. You know, one of those things is that pediatric mental illness is common. So nearly 20% of all kids will experience a pediatric mental illness at some point during their childhood, something that is impairing for them, right? And so when you think about how common that is, right, you might say, gosh, that explains the cause of death, but there does not have to be such a tragic outcome from pediatric mental illness, from this thing that is so common in the population. So there are lots of variables that have likely been contributing to that increase in suicide rate before the pandemic, right? Of those variables, what we were kind of looking at was, in general, among Americans, the time between symptom onset and treatment is about 6 to 11 years, right? So it takes nearly 5 to 11 years from symptom onset to when someone starts receiving treatment. And for kids, that's a significant 11 years. That's a long period of time that a kid has been experiencing mental illness. And from there, what we frequently see is only about 20% of kids that are experiencing mental illness receive the care that they need. And there's a number of variables for that. And it's not just mental illness, right? That is something that I do want to point out. It's not just mental illness that can cause these tragic and bad outcomes leading to suicide, right? Things like adverse childhood experiences, social drivers of health, systemic racism that I was already talking about before, and then other institutions that we see as well, like school, which many of us believe is important, critically important for child development, but academic pressure, academic performance, frequently reported as the greatest source of stress for children and adolescents. School can also be a place that kids experience peer victimization and bullying. And in Durham, what we frequently see, or what we have seen, is that when school starts, compared to when kids are on break, there is a 60% increase in rate of pediatric mental health emergency department visits during that academic time. So when we think about these other institutions and how they impact kids, we have to consider the role of mental health in those settings. So there are lots of variables that could be contributing to what we have been seeing over time, and to the community that impacts us in lots of ways, right? Pre-pandemic, 2019, mental illness was the most common cause of dropout in school of any disability group, right? And nearly 70% of kids in the juvenile justice system had been experiencing a mental illness, many of whom were probably in the juvenile justice system because of an untreated mental illness that they were experiencing. Pre-pandemic, for those of us that work in child mental health, many of us would say we were in a pediatric mental health crisis. And then the pandemic onset. And what we saw was increased loneliness, increased isolation, increased parental distress, increased substance use disorders across the entire population, the murder of George Floyd, exacerbating racial trauma and highlighting the systemic racism that so many individuals have experienced. And we've just seen that temperature rise. And so the numbers that we've seen starting at the pandemic and coming through the pandemic, 70% of parents were reporting that their child was experiencing adverse mental health concerns. They were worried about the mental health of their child. Additionally, we have seen a nearly twofold increase in depressive symptoms and anxiety symptoms among children and adolescents, right? Where nearly 20% of kids experiencing depression that is impairing them, 25% of kids experiencing anxiety that is impairing them. And I fully believe that the full outcomes that we are going to see, right, the outcomes from the pandemic, we are going to continue to learn over time. But we already had a pediatric population that was in crisis for mental health reasons. And then we had this event that raised the temperature across and has really concerned many of us in the child mental health field for where we are going in the next direction, and something that is critically important for us to address and thinking about America's kids and also America's future as far as managing pediatric mental health in children.
Sure, absolutely. Thank you, Dr. Copeland, for that opening. Dr. Maslow, I'd like to move on to you. And Dr. Copeland touched on this a little bit. I wonder if you can, we know that the pandemic has placed a strain on mental health across the population. Can you talk about how that's played out amongst teens in particular, and what other factors are driving this increase?
Yeah, well, thank you all. Thank you for having me. I think Dr. Copeland spoke pretty clearly about a lot of what the contributing factors are, and I can certainly expound on that. I think one thing that for me personally has brought it home, working in the hospital and seeing kids coming into the hospital after having had serious suicide attempts, is just the difference of being in the hospital today as opposed to before the pandemic. And I think if we had 2 children, young adults, come in with a Tylenol overdose in a 6-month period, we would think that was a lot. And this past spring, it was happening, 2 in a week. And so it's been about a 15-fold increase of children, young adults coming to our hospital because of such serious suicide attempts. And so I think just personally walking into the hospital now and working with our team and with the staff and the nurses, it's unlike anything I've experienced in doing this for 20 years. And that's the tip of the iceberg. I think, Dr. Copeland starting off by saying that the worst outcome is children dying by suicide. And that is happening. And then that is the tip of the iceberg, that there is a large amount of distress that's happening that doesn't rise to the level of that. And I think the experience again of seeing different marginalized groups having a disproportionate negative effect, LGBTQ plus children, young adults coming in, certainly seeing that group having more vulnerability to this, these serious outcomes. And in Durham, we've actually seen both Black youth, but also Latinx, Hispanic youth presenting at much higher rates than we've ever seen before. And, I think we don't necessarily fully understand that. So there's certainly some broad-based distress across all of our communities and all of our children. And then there are groups that I think are experiencing that more. Certainly the broad-based, like what about the pandemic led to this? Being out of school and being disrupted from the connections likely has a role to play in that. In North Carolina, over 3,000 children have lost a caregiver due to COVID. So clearly the stress of the actual illness of COVID is a part of it. Loss of services, children with disabilities have, like autism or intellectual disabilities, they've lost the services that they may have had beforehand. And so this just, all the things that are going on in the community that are distressing and causing stress for so many of us with the pandemic have been, amplified for young people. Ultimately, I think we have an opportunity to look at places like schools, community connections in other ways, and find ways to support children and families, but really acknowledging that this is a crisis, that this is the fourth or fifth wave of the COVID crisis, and that there probably more children are going to have bad outcomes because of the mental health crisis than directly from the virus. So it's definitely an opportunity to take this as the Surgeon General has just declared this as an emergency, and try to address this in a variety of ways.
Absolutely, thank you. Certainly a very stark picture you've painted already. Professor Hill, I'd like to move on to you. We've talked a lot about how the pandemic has exacerbated problems. You study the biological and social factors in child well-being. What are some of the things you've learned about some of the predictors of mental and emotional problems that lead to self-harm in children?
Yes, I think it's really, first of all, I want to thank you guys for pulling together this panel and inviting in guests to hear about this important topic that we all have been personally experiencing, but also aware of in terms of a pandemic, not just in the US, but globally. In terms of self-harm and what we know from epidemiologic research, there are some consistent constellation of factors that remain pre-pandemic, but I think there are some specific elements about the pandemic itself with COVID that has exacerbated some of these conditions. So specifically, we know from the research that a lot of the individuals who do self-harm or have suicidal ideation, where they think about ending life or other ways in which they would like to become more disconnected from society, is that they have had long-standing reports of symptoms. And I think that's an issue in and of itself for our public health and our clinical practice for mental health, and how we see children and their expression of need for their mental health, that this is not just something that's specific to adults, but that there are ways of collecting data and analyzing data and even synthesizing it, that we know as young as 2 or 3 years of age that we could see that there are developmental pathways that can lead to mental illness that's later presented and diagnosed, and ultimately in some cases hopefully treated. Second factor is comorbidities. We see that there in many of these cases for outcomes related to self-harm or more adverse outcomes, that these individuals aren't just dealing with one specific type of mental illness or condition or area for growth, but that it is across multiple different diagnoses if they were to be clinically treated, which takes a little bit more time and thought for what is the best approach for this individual outside of just classroom management, which is how a lot of children present in a clinical setting where they've been referred due to behavior that's inappropriate in other contexts outside of the home. A third factor is what we think is the interesting thing in the research, and it's really emerging now that we're starting to have some of these larger cohorts and decades of research in the US on adolescents, is around peer relationships and this concept of isolation and loneliness for the individual, him or her, that the individual is experiencing. So trying to see how those two things in particular have pathways to outcomes related to self-harm and worse outcomes. It's really interesting, especially when we think about what has happened since COVID, where youth were pulled out of their natural social settings and ways of engaging with peers and systems such as school, sports, and church or other organizations that they were a part of, and put on virtual platforms that really opens them up to people who may be outside of their inner circle of safety and security, that could expose them to problematic exchanges or what they would consider bullying. I mean, I think in the literature it's really alarming if we think about what that means for adolescents, which is kind of different for what we think about impacts for adults. In that pure bullying is actually, if you rank it in terms of the literature, a bigger factor for outcomes for how that individual feels in the moment compared to whether or not they experience child maltreatment from a caregiver over the course of their life. So that's huge. And then realizing that if children were put on virtual platforms where their main way of socializing with individuals were through these open channels of communication, and that they had a lot more intake of it because that was their main way for schooling for a lot of people who stayed in place in the home during the pandemic, or increased their online social media consumption or creation. That's really impactful, and I'm not sure if we have some answers or any recent research that's really speaking to that or interventions around that, but I think that's one way in which COVID in particular has possibly even elevated or exposed people more to those negative experiences. And then the counterintuitive part of it is that even though they're having more engagement, which you would think would reduce loneliness or isolation, it doesn't. So these technological platforms, although they were more readily available and used, not just in the US, but across the world, it did not possibly address isolation and loneliness, which is a personal perspective that an individual feels. And it's interesting when you look at adolescents and their network. So loneliness is not a factor of how many friends an individual has or how warm their home environment is. It is a very personal perspective. And I don't know if we even have enough literature or research or clinical practice around this construct in and of itself, and what does that mean in terms of trajectories for mental health conditions later. And then lastly, the last factor that is a key contributor across the literature and what we see in our research specifically for these longitudinal studies of adolescent mental health is just prior history. So whether it was not just the previous report of symptoms for the individual, but the fact that a lot of this is intergenerational, where they also have parental report of poor mental health condition behaviors or disorders. Whether or not those conditions are treated or untreated doesn't really matter, just the fact that they exist. And maybe that has something to do with the lived household experience that the youth are exposed to. But we know that parents struggle, especially when there are limited resources, and having these social determinants of health are really important, and what kind of supports are provided, because we see that mental health related to self-harm for adolescents is consistent regardless of socioeconomic status. So when we control for that, we still see that it is a problem regardless of social status. But these social determinants of health really relate to what are the key needs that a family has, whether that's housing, food, and other securities that are necessary to not worry and to focus on other priorities or engagement in their functionality for day to day. But then there are also structural drivers of health, and these are those systems barriers, whether it's racism, whether it is implicit bias, or other factors that specific communities experience that drives them to be marginalized or not as engaged to having access to opportunity or assets to help build their strength-based position. And we also notice that these trajectories not only differ based off of race ethnicity, with research that is really inclusive and tries to understand pathways for Native Americans, African Americans, and whites specifically, as well as other cultures for such as ethnicities such as Latinx, but also by sex. in that the onset of some of these symptoms that eventually become, a composite for an actual diagnosis, that they differ. In the pathways leading to the predictors or precursors leading to these outcomes differ by sex and by race ethnicity. So those are, for me, just the key things that I wanted to add.
Absolutely. Thank you so much. Absolutely. Sorry, I think your audio dropped out, and I didn't mean to interrupt you there, Professor Hill. Thank you, all three of you, for those comprehensive openings. More to dig into than we could possibly get to in an hour, but I'm going to dig in here and do the best we can because we've got a lot of specific questions. Thank you to everybody who posed questions in advance. You can add questions to the Q&A window at any time. If you'd like to ask a question in person, raise your hand in Zoom, and we will unmute you when your turn comes around. If you're calling in by phone, you can raise your hand by pressing *9. Dr. Copeland, I want to come back to something you said, that it can take 6 to 11 years often for symptoms to be noticed and then treated. For parents and caregivers and people in schools, what kind of things should parents and caregivers be looking for as an indication that it is time to seek help? And I realize that's very broad, but I'm guessing there are some fairly standard things that you look for that are an indication that something is wrong.
Right. Well, and thank you for that question. And there's lots of different angles you can kind of think about and how we identify kids. What systems are identifying kids. For parents that are with their kids, very frequently when we think about certain mental illnesses, anxiety, depression, things along those lines, we are seeing behavior changes, right? One of the most common things that we see among kids is increased irritability, increased anger. And so if you have a kid that is having difficulties in other ways, maybe more irritable than they used to be, to consider, could there be some other condition going on? The other piece that I would put there, and I can go back to the anxiety and depression, thinking about, is your kid worrying more? Do they seem more sad? Are they losing interest in activities? The other piece that fits with all of that is during the pandemic and even before, I think a lot of us were saying we need to be checking in on each other, right? And for parents to be asking their kids if they're feeling sad, if they're feeling worried. And while it can be difficult for parents, I think there does need to be a role of bringing up suicidal ideation or suicidal thoughts, right? So, and you can normalize that in some ways of saying, gosh, I've really heard a lot of kids are struggling, and that these past few years have been hard for so many people. Have there been any times that you felt sad, any times you felt worried, any times you've thought about hurting yourself? Because if there have been, please tell me, right? The parent being a source of support there and a source for the kid is very important. And both Dr. Hill and Dr. Maslow touched on this thing that I do want to point out there too, is for the parent to also be very mindful about how they are doing, right? If the parent is having difficulties, if the parent is feeling sad, if the parent is feeling anxious, to be mindful of that and to think, gosh, should I get some help myself? Because we know that how parents are doing can impact how kids are doing too. So really being mindful about that whole family unit and that whole dynamic, I think can be helpful and hopefully encourage conversations in the household that aren't typically had and historically have not typically been had.
Absolutely. Thank you, Dr. Copeland. And that's obviously a question that we could spend a couple of hours on its own. But Dr. Maslow, I'm wondering if you could talk to us a little bit about when it's time to seek care, the places and the ways that care can be sought. Because, of course, what we want to avoid, as you talked about earlier, is people coming to the emergency room with a suicide attempt when hopefully there are many interventions that can be made before that. So when somebody has a concern about a child in their care, what are some of the avenues that they should be looking to pursue initially?
Sure. I think that as Nate was describing, the place to start ideally is with prevention. And so that is, I think, the notion of for parents, for caregivers, teachers, to try to put on your own oxygen mask first. And so what does it take to have support so that you are, as a caregiver, as a parent yourself, able to take care of yourself? I think I remember in training, a psychologist I was working with who said that if we had $1 to spend on pediatric mental health, we'd actually spend it on the parents, and really thinking about helping the parents themselves be able to take care of themselves. And it's not because parents are the cause of their child's distress, it's because they're their best asset for supporting them. And so, and similarly for teachers. And so I think from a prevention side, supporting teachers, supporting parents, camp counselors, the people who are on the front lines of taking care of kids, that's what, if we go back to like what we really need, that's the place to start. If you have a concern about a child as a parent, or as an adult who cares about the child, certainly often the first point of access is primary care. So whether that's a pediatrician, a family doctor, nurse practitioner, I think that's a really good place to start. When we look, nationally, primary care providers see 70% of the mental health visits in the country. So primary care is a really good place to start, and they can speak with you as a parent about the child's needs. They can help begin an assessment, and they can do some treatment, or at least help make connections. So I think, again, many places, that's a really good place to start. In North Carolina, we have something called the North Carolina Psychiatry Access Line, or NCPAL. It's part of a national set of programs that are funded, originally part of the 21st Century Cures Act, created funding that HRSA, the Health Resources and Service Administration, that part of DHHS at the federal level, dispersed to 21 states. And with the American Rescue Plan and subsequent congressional action, that these telephone consultation lines now are in most states, and are being expanded even further. And basically what we do, we run it out of Duke in partnership with UNC. If a primary care provider sees a kid and they have a question about their behavior, about their treatment, they actually can just call and essentially have a hotline to speak to a child psychiatrist in real time and get support. And so our goal with working with the state of North Carolina and this NCPAL program is to help that workforce of primary care providers. There's about 6,000 or so primary care providers who treat children in North Carolina, who have Medicaid, when we've looked at some of that data. And most of them are not child psychiatrists. There's only 13% are child psychiatrists. The majority of them are primary care doctors, nurse practitioners, PAs, family doctors, pediatricians. And they're doing this work now, and our goal is to support them. So ultimately, if you're working with a kid or know a young person, I think bringing them to their primary care provider is a place to start access. There certainly are resources in between primary care and the emergency room. There's a really great program that we're trying to replicate in North Carolina that's out of Long Island, called Northwell is the health system. It's, I think NPR had a story on it last year. And we're attempting to work with the Northwell program to bring it to North Carolina. But basically, you have a relationship between the school and the health center, and so that the school can directly send a child to get access with a child psychiatrist or pediatric psychologist in real time, like same day, versus sending that child to the emergency room. And that program reduced ER visits by about 50%. And so I think, as someone who's spending a lot of time trying to address this, with working with our amazing partners at the state, we need to get to where kids are, and that's in primary care and in schools, and have parents and caregivers know how to access those services. There are vulnerable groups, so kids in foster care are one in particular, where really working directly with those service systems to help put mental health at the forefront of what children need. When we know they've been exposed to something like trauma or are in a vulnerable place like foster care. So I think the thing to do is not worry alone, and to try to reach out for help from other trusted sources like primary care.
Absolutely, thank you, Dr. Hill. I wanted to come back to something that you said in your remarks, and certainly, we don't want to alarm parents any more than parents are already alarmed, as a parent myself. But you mentioned about developmental pathways. Sometimes there are certain things that can be picked up on in children very young, as soon as 3 years old, that can maybe an indicator of problems. Are there things that parents kind of should be looking out for at that particular age, or can that be more harmful than anything if we're trying to kind of helicopter a 3-year-old and trying to predict any potential problems that might come down the road?
Yeah, I would definitely caution against engaging with any child in a like diagnostic sense, but just enjoying the relationship. I think that connection is really the most important factor there. But there are some things where if you talk to a provider, that they should be able to help a parent discern the difference between tantrums and real irritability at a younger age. I mean, I think there are different behavioral patterns that a parent might recognize as being specific to a child, but talking to a provider could help them realize what is actually abnormal or a clinical event, even. Sometimes that's why being in settings related to childcare or pre-K programs in those early years are useful, because teachers or caregivers in those settings are able to see what is normalized behavior, because there's going to be a general level of crankiness among preschoolers in general as they're trying to understand their own sense of personal and social justice with peers and having their needs met. How do they get that fulfilled? But there are instances where it is clear to people who are trained what is abnormal behavior that's beyond the typical amount of noise that would be expected for disruptive behavior or dissatisfaction. So in many cases, we've been able to look at data, thankfully, through 0 to 3, and trying to understand some of the symptoms that have been observed in the preschool years, and seeing how do they track on to diagnoses that are made in the early school years when these children begin school entry. And I think one of the main ones that has stood out, or at least that I recall that was very telling, was about the frequency and the intensity of tantrums. Not that tantrums are a bad thing inherent of itself, but there does become a threshold where it could be out of range.
Absolutely. Thank you very much. Dr. Copeland, wanted to come back to something you mentioned in your introduction. You mentioned how this was already a crisis before COVID worsened it. Is there any hope that as we kind of emerge from the pandemic, if indeed we do, that there is any kind of correction that happens? Or are we looking at a generation of younger teens and children who, because they went through that, it's kind of, done damage that doesn't simply revert to the mean, once we're through a pandemic? And if so, what can we do about that?
Sure. The first thing that I would say, and as a child psychiatrist and us as a panel working in childhood mental health, is we're talking about it right now. In 2019 and before the pandemic, when this crisis was going on, we weren't talking about it as much as we are now. Fortunately, kids are pretty resilient people. And with support and the way that we can, as a community, as a system, support them, there is lots of opportunity there. Certainly talking about these other ways that the health system can support primary care doctors, can support the school, can support the community. The way that we are discussing bringing in the community, right? Whether that is peer support individuals that might be able to help kids that have been through depression or anxiety, bringing in family members that have had to navigate the system themselves. There are lots of opportunities for us to improve pediatric mental health into the future. I believe us just having this conversation right now, right? People being here and listening to this conversation is the critically important step that we've been needing. Dr. Maslow was talking about these different integrated care programs, whether that is these access lines, different models of providing care in the primary care setting, like collaborative care, models that we are seeing expand more and more across different health systems. How we can continue to support schools, whether that's the identification of mental health needs within the school setting, how we can help students learn to manage their own emotions, right? Learn skills for taking their own temperature and managing their own emotions to the future, whether that's different types of trainings, things along those lines. There are lots of opportunities moving forward. In many ways, we might be in a better spot now to be moving forward with those increased trainings to engage communities better now than we were before. So I am ultimately hopeful that we can come out of this, or we can move forward in a way that is going to be positive, in a way that is going to support kids and is going to support communities.
I just want to, I think, Nate, or Dr. Copeland, I think, the idea of this being both a challenging moment, but also a hopeful moment, I think is really important. I think that you're, I think, on track with that. I think our, people and children have been through a lot over generations. And so I don't know that this moment is worse than World War II or, periods that have happened in other traumatic things that have happened in this country. And the ability to respond to it is really important. I think young people themselves are talking about it more. And so in many ways, part of the recognition of this being a crisis is that young people are actually speaking up about it themselves. And so the youth themselves are probably our greatest allies in addressing this, and not just seeing this as what the adults need to do. It's actually really, supporting young people and listening to them. And I think that is where some of this intersects with things like gun violence. And I think the federal law that was just passed that specifically included funding for programs like these mental health programs I mentioned earlier. But when we think about death by suicide, the greatest risk factor is access to a gun. Whether someone has a suicide attempt or not is like, many more people have a suicide attempt than die by suicide. But if you have access to a gun, your risk of dying by suicide is much greater. And so there really is an intersection of this gun violence crisis and the suicide ideation, youth mental health crisis, and truly addressing safety by addressing the access to guns for young people is directly a part of this. And so what's happening, with that first piece of federal legislation is important, but continuing to put means in place so that if a young person does have a crisis, it doesn't result in their death, because many people have had suicide attempts who then are able to move forward and not necessarily have that define their whole life. But if they die by suicide, then that's sort of the coda. That's the end. And so other countries have put in place blister packs for Tylenol, so that if you put, like at some European countries, if you have Tylenol in a blister pack, it would take you like several minutes to pop, use the blister pack for the pills to be able to take enough to take a fatal overdose. And in countries that have done that, there's been a decrease in liver transplants because of Tylenol overdoses being reduced. So there's some like sort of upstream. Again, I want to focus on prevention and what we can do to help youth be well and thrive. And on the other side, for those who get to the point where they are thinking about suicide, what are the things that we can do to really keep them safe? And those are, in our country today, the gun violence component of this, I think, is cannot be ignored.
Absolutely. Thank you both for that. Dr. Hill, I'd like to come back to you. We've had a question in the Q&A that asks, is there any evidence if students learning virtually who are showing their home setting in the background of their screen, whether that played a role in socioeconomic discrimination that has also promulgated bullying and in turn led to depression and anxiety and other mental health disorders?
Yeah, I don't know if the literature today can be considered of having sufficient strength because it's very new, and we would still need to synthesize that. But there are studies that are being done looking at the virtual learning environment and screen sharing in particular, and how that related to academic outcomes. I haven't seen anything that relates it back to mental health specifically, but the screens on, screens off element is interesting from both sides of it. One of which is privacy and the need for that, and how kids, home environments were showed, and that could have a negative impact But then there's also the push or the need for having kids feel more engaged by having screens on so that they can actively engage with the teacher and other peers in a setting. And I'm not sure if the right balance was ever achieved with that, at least from my experience as a parent, because I have 2 teenagers, and we did do the virtual stay in place learning for a year and a half, which was really difficult. But that's my perspective. And then just from a research standpoint, I think it's still emerging research that there isn't a clear consensus of what the correct way forward is. But it's interesting to see the data that is coming out on it, because I don't think that virtual learning is going to go away. And in terms of the pure bullying and the relationship that kids have in terms of socioeconomic strata, I think they already know, even in a school setting, they kind of self-segregate according to who they believe have and have more. And that is just an ongoing dynamic of our society and how we're structured. And I don't know how best that can be addressed, because it's just a long-standing issue. But we do know the detrimental effects of peer bullying in general, and I think that is cause for concern for all adolescents. The other point, just to pick up on what Gary was talking about, and as well as Nate, in terms of this idea of talking about it, I do want to emphasize that I believe that technology isn't something that should be vilified just because it can open up more channels for peer bullying or other sorts of negative influences, or people just seeing relative to themselves how other people might be doing better because of curated content that they post. There's lots of literature to show how wonderful technology has been in terms of connecting youth, and specifically around this issue of mental health, where people have been able to build out social networks for support for themselves and to be honest about what they are experiencing. So there are some platforms for that. It's just the caution about COVID and how that opened up these platforms for all youth, whether it was supervised or unsupervised youth. And I think parents could be more attentive about not just how much time youth is spending on their device, but where are they going and what are they doing is the bigger question, just to check in and ask, because that could be a great opportunity for the talking, to engage in conversation and get a sense of where your teen is or adolescent, specifically on different topics.
Absolutely. Thank you very much. Dr. Copeland, I want to come back to you, and I'm interested in getting everybody's perspective on this. Many teenagers by nature are quite solitary creatures, will retreat to their room, and this is part of their normal kind of separation from their parents. But of course, we're seeing this now in the context of increased isolation in general. And so I'm wondering, for parents, as a parent of a teenager myself, who of course didn't have teenagers before the pandemic, so didn't parent, like most parents with teenagers now, didn't necessarily have experience of having a teenager before there was a pandemic. Now they do. So all this leads up to the kind of things to look for. We've talked about kind of behaviors to watch for, but when it comes to isolation or teens kind of withdrawing, there's an element that's a natural amount of spending time by yourself, and there are certain ways in which maybe we can see that it's becoming a concern. So are there particular things that we can look for there? And also, I think parents and caregivers would appreciate any kind of good conversation starters. We all should know our own children, but teenagers in particular can often be reluctant to talk about topics, especially as it pertains to their own mental struggles. So do you have any suggestions for parents approaching their children to talk about the problems they might be having, and any particular isolation related warning signs to maybe look for?
Sure. Great question. I think we've all been teenagers and have isolated in some way or another. And I mentioned this a little bit earlier. Very, very frequently, what we are looking at is the kind of body of work is to how your teenager is doing, right? And how your teenager had done in the past, and how they're doing now. So if you have a teenager that has always been a straight A student, or has done relatively well in school and is isolating more, but they are still doing relatively well in school and are still engaged in the activities which they enjoy doing, right? I think that's when our concerns are just a little bit less. But if you have a teenager who you are noticing much bigger changes, right? They used to do well in school they're not doing well in school anymore. They used to have a lot of friends. Those friends are changing, or they are seeing a reduction in the number of friends they have. They used to have activities which they enjoy doing, and now we're not seeing those same activities anymore. When you take that kind of body, that general just view as to how that teenager is doing, when you start seeing from lots of different angles that your teenager is getting worse, I think that's when we really start worrying, and that's when we really start having other concerns. As far as conversation starters, I think for parents, there have always been topics that have been difficult for us to bring up. That as parents, addressing certain things that our kids are observing in the world, addressing certain things that our kids might be experiencing, or topics that we know are important. Frequently, I think that's our own challenge as individuals to discuss these very sensitive topics. It is okay to be uncomfortable asking those questions if you're asking it from a place that is checking in on how your teenager is doing. It can still be difficult to bring up those things, because sometimes, what if they tell us something we don't want to know? And that's scary. That is scary. As parents, we do lots of things that can sometimes feel scary. And being able to say, okay, I'm uncomfortable asking this question, but I need to check in on my kid. I think having that just in the back of your mind, and not worrying so much about, am I doing it wrong? Am I uncomfortable? But this is something that I know I need to do. Or maybe my kid says something, and gosh, I sure feel uncomfortable bringing this up, but let me still do it. Because just bringing it out into the open, right? What's the saying? If there's an elephant in the room, introduce it, right? Being able to use words to highlight that and to be able to address that, to at least start that conversation, to start that space is what is important for parents. It's what's important for us in the entire community, to be able to start those conversations. Did I answer that question adequately for you?
Absolutely. You did. There's a follow-up, and I'm gonna throw it to Dr. Maslow, because something that I have experienced as a parent, I dare say many others have too, is teenagers with which you attempt to start a conversation and they just shut it down, because teenagers, naturally their parents are not the people they always want to talk to about things, and it's tricky because you're trying to help and doing it in the tenderest way possible. And I realize that you don't have all the answers, because if you did, you would have written a book and every parent of a teen would have read it and fixed this. However, I'm wondering if there are any suggestions you can offer, when for parents and other caregivers who are trying to communicate with their teens with the best of intentions and are just being shut down, especially if they're at the point where they're thinking, I need to seek help for this child, but I want them to be on board and understand why I'm doing what I'm doing. Is that something you see a lot of, and are there strategies for approaching that?
I'll step back one level further from what your question is, but then answer it. I think that one real helpful way of thinking about young adults is something, Sharika and I have studied this, called the Positive Youth Development Framework. So the idea is that adolescents and youth are a resource that helps their own growth, and that seeing them as contributing to society, to the family, and to the parents is a place to start. And so really taking, I think in general, a strength-based approach to young adults is really important. And it's not because they're fragile and need to be built up, but because they actually truly are the agents of their own growth. And I think engaging with them in that way can be pretty meaningful. And so how to translate that theory into action, when parents are authoritarian and say, I do this, you do this because I say you do this, and are authoritarian, it doesn't work terribly well for young adults. But if you're authoritative, meaning you're present, you explain and help them understand what you're asking, and then you're present for them, that is the approach that leads to these conversations. And so honestly, again, I don't have teenagers yet, but I have, almost a teenager, and it's hard. And it's hard to engage with young people because they may not be at the moment when you want to talk about it, that may not be the right time for them. And so I think it's kind of being open to those conversations and taking advantage of moments that present. Specifically, the way to do that is to spend time with them and try to find ways to have, family dinners, have activities that they enjoy. And that space is where those conversations will happen. If you are concerned about something and you need to address it in the moment, I think you can be direct. We really need to talk about this because I'm worried about you. And we need to make some time to do that. And we need to do that. And many teenagers will not respond to that, but hopefully they'll hear that concern. So, young people have had a huge effect on our world in a positive way, and they're continuing to do that now. And across all the many crises that we're facing. And so, so as parents, I think it's probably not being afraid of them and not being afraid you're going to make it worse, but just continuing to show up and continue to be present, and then trying to engage them and have positive time with them would be what will allow those conversations to happen.
Absolutely. Thank you. Thank you very much. We're getting close to time here, but I want to try and cram in as many questions as we can. Dr. Hill, we've had a question here asking about like some of the laws, the things we've seen coming from the Supreme Court, and the kind of banning trans girls from playing sports, limiting classroom mention of race and racism. Do we expect, and I'd like to hear everybody else's perspective on this because it actually might be a good way to close, do we think that that's going to just kind of add to the burdens that teens are facing and potentially exacerbate this?
I think that all these legislations offer opportunities for conversations. So developing a sense of identity, a sense of positioning in their worldview. And I think the context is really great for them to grapple and struggle with the complexity of the world. I am least concerned about these broad macro level legislations as I am about the channels in which we're allowing kids to discuss this openly in the school settings in terms of reproductive health or critical race theory and other factors. I think having a healthy dialogue that can be facilitated by people who can create safe environments for all the students in a classroom to have that conversation is important. So just having the legislation that could spark conversation is even more important to have a guided adult who could guide a healthy, robust, or rigorous conversation about it. And if that isn't present, I'm not sure if it's healthy or unhealthy for them to just move forward and talk about it in that school setting. Because myself, I have mixed race teens, and for them, their experience in a classroom is very different being in a predominantly white school setting where the conversation isn't really folding in all the different perspectives, and it could be insensitive to the individuals who are different or have a different ancestral or heritage background. So I think the legislation in and of itself isn't bad, but I do hope that as adults we create channels for our youth to have these conversations and grapple with the complexity of our society.
Absolutely, thank you. And Dr. Copeland, anything to add to that? And since we're wrapping up here, focusing on some of these elements of hope that we have is probably not such a bad thing either.
Sure. Well, again, the conversations that kind of what everyone has been saying about us being in a place where we are talking about mental illness, whether that's in adults or in kids, and understanding how the systems that we exist in impact those kids. I agree with Dr. Hill and thinking about legislation, this kind of thing on paper. At the end of the day, how does that impact the kid, that individual kid on kind of the micro level? And if we're able to have these conversations, if as adults we're able to support kids when they're going through these challenging times, which adolescence is, right? Creating your own sense of identity, developing your own sense of who you are. And as adults, being able to support kids through that journey, right? That there's not an end point there. It's supporting them through that journey of who they are and how they exist in this world. I do believe that if we can do that, both for ourselves and for kids, we can continue to move in a better direction. There were lots of elements that were mentioned in the past hour. You know, you can look at this and say, gosh, there are so many complexities here. There is so much that is wrong. But the other way to view that is there is so much we can do. There are so many opportunities that we have right now. And there's so much low-hanging fruit that we can engage to improve the mental health of kids as we move on into the future.
Absolutely, thank you. And Dr. Maslow, I'll come to you for a final word on some optimism. And I do also appreciate everything you've talked about in terms of how we interact with our children. So any parting thoughts from you?
No, I think I think this has been a good discussion. I think that the fact that we're all talking about it is the most important part. I think that this is a moment at the federal level where the most recent legislation, again, about gun violence prevention and addressing mental health is a really good starting point. And so building on that momentum at the federal level in North Carolina, the Department of Health and Human Services, the governor, and the legislature are also making pretty substantial investments in youth mental health, which is really important. Expanding Medicaid is probably the most important thing that the state could do. And so again, as we think about like what are the broad things that are on the horizon that actually could make a huge difference, more than anything else, access to healthcare, expanding Medicaid, those are the things that actually would change this crisis and stem the tide. Getting individual treatment for individual children is critical. We need more providers. We need more people to do it. But this really is a will and a policy approach. And as a society, do we care enough to do that for children and youth at this time, and see this as the next phase of the pandemic? The amount of resources we put into fighting COVID, a fraction of that would make a huge difference in making treatment available for those who are symptomatic and supporting parents and families so that they can care for their children during this time. So I don't know. I think the idea of really this is the next wave of the COVID pandemic, and there is beginning to be momentum at the federal and state level to do that, and hopefully at the local and community level we can all sustain that and really have a robust response to say every child who has a mental health condition needs support, every child needs a safe place to live, and every child needs food, and their families and caregivers need to have access to leave so they can care for them. So I think that we have the right policy prescriptions out there, and it's just a matter of what happens during this time. But I know all of us are grateful for the attention to the issue and continue to talk about it. And then every one of us has the opportunity to support an individual young person, which is really what they need. So I guess those are
absolutely
my last words.
Thank you. We could certainly talk for another 3 hours on this, but we've reached time, so we'll call it there. Thank you, everyone, for joining us. Thank you to our panelists, Nathan Copeland, Sharika Hill, and Gary Maslow, for sharing your expertise and perspectives. We hold regular briefings on the pandemic, reproductive rights, politics, and everything else this perplexing decade has been throwing at us. If you'd like to be notified of upcoming events, please email dukenews@duke.edu. In the meantime, please be kind, talk to your kids, and listen to your kids. And I'm now going to go